Welcome everyone to VWD treatment across the lifespan for women, girls, and people with propensity to menstruate. These trainings are supported by a cooperative agreement funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the CDC or the Department of Health Human Services. This program is number 3 in a series of accredited provider education activities being jointly provided by the University of Nebraska Medical Center and the National Hemophilia Foundation. Today's focus. The program will provide interactive conversations about evolving treatment needs of women, girls, and people with propensity to menstruate across their lifespan, including management of heavy menstrual bleeding and preoperative care for both cisgender and transgender patients who were assigned female at birth. And my name is Nicole Scappi. I'm a manager of education here at the National Hemophilia Foundation. I've worked at NHF for about 5 years. I am based out of Pittsburgh, Pennsylvania, and I myself have von Willebrand disease, along with my mom, my siblings, and my late grandfather, who actually never received a diagnosis. And I also had the pleasure of serving on the VWD Diagnostics Guidelines panel and was proud to contribute to those guidelines that were released in 2001. That's just a little bit about me. It is now my pleasure to also introduce both of our speakers, and I will start with Dr. Angela Wyand, and she is the Clinical Associate Professor in Pediatric Hematology Oncology, co-director of a combined hematology gynecology program serving young women and girls with bleeding or clotting disorders. And her research interests are in genetic modifiers of hemostasis and thrombosis, women and girls with bleeding disorders, hormone-provoked thrombosis, and von Willebrand disease. Our other presenter is Dr. Nathan Cannell, and he is the Associate Physician in the Hematology Division at Brigham and Women's Hospital. He's Associate Professor at Medicine in Harvard Medical School, Chief of Medicine at Brigham and Women's Faulkner Hospital. And Dr. Cannell's work focuses on the spectrum of von Willebrand factor in health and disease. Our program agenda for today. We're already kind of at that beginning. I'm giving you some speaker introductions here. Next, we're going to have Dr. Wyand talk, and she's going to talk about background on VWD treatment across the lifespan, and Dr. Cannell as well. We're going to have some breakout rooms, and then we will have a group summary and discuss some of those breakout room discussions at the end. And post-activity, NHF will be uploading the speaker slides to NHF website, and resource document will be shared to support the learnings from today's session. Our learning objectives. So you all should have received these in an email, but in case you didn't, here they are. So at the conclusion of the activity, the participants should be able to characterize the evolution of treatment for von Willebrand disease across the lifespan for women, girls, and people with propensity to menstruate. Identify treatment options for women, girls, and people with propensity to menstruate living with VWD, including preoperative management for patients requiring surgery involving cardiovascular interventions. Discuss gender-affirming care in the context of VWD and collaborate with the healthcare team for shared patient-centered and population-focused problem solving for those experiencing bleeding disorders as derived from discussion-based treatment strategies and evidence-based practice. All right, and for our learners today, feel free to add any questions in the chat today. And when we do go into those breakout rooms, I invite you to really turn your cameras on, engage in discussion, conversation, and ask questions. And I also want to highlight that the recording will be stopped in the breakout rooms. So just wanted to make sure that you all knew that that's a safe space and there will be no recording there. And with that, it is actually my pleasure to pass it over to Dr. Wyand. Dr. Wyand?
Thank you so much. I'm excited to be here today talking with you all about important topics. I'm going to try to go through a quick run through just of some different issues with this patient population encounters and how we like to manage those before getting into even more interesting topics with Dr. Cannell. Next slide. So I think we're all aware of what von Willebrand disease, but it's the most common inherited bleeding disorder, and it does occur equally in men and women. But we do know that people with the propensity to menstruate do encounter some different treatment challenges in the form of heavy menstrual bleeding, issues around delivery of children, as well as perimenopausal bleeding. Next slide. Von Willebrand's disease has two major functions. We know that it carries and protects factor VIII, which is important, but also that it serves a role in primary hemostasis, serving as a bridge between platelets and the injury site at the blood vessel. Next slide. So I think we all are pretty aware of kind of the signs and symptoms of VWD. Oftentimes patients will present with epistaxis that lasts a long time, oral bleeding that lasts a long time, or is more excessive than we would expect. Oftentimes these patients have excessive bleeding after injuries or after procedures, even minor procedures. They can have easy bruising or abnormal bruising that's quite big or lumpy, heavy or long menstrual bleeding, as well as bleeding into the joints and muscle. I think it's really important for us all to remember that normal is such a tough term. I think a lot of times with these patients when I'm seeing them in clinic, if you ask more general questions like, how are your periods? I can't tell you how many adolescent girls have told me they were fine, only to find out that their bleeding was about the opposite of fine, in my opinion, right? Where they're bleeding for most days of the month, or they have bled down to a hemoglobin of 4. But if that's all you've ever known, especially if you grew up in a family with von Willebrand's disease where your mother had similar types of bleeding, you're not necessarily going to recognize that as a next slide. So thinking about this population of women and girls and people with the propensity to menstruate and kind of how they progress along their lifespan, I think that as children, prior to menarche, men and women with von Willebrand's disease have pretty similar symptoms, right? Talking about that oral bleeding, epistaxis, abnormal bruising, possibly if they have procedures, which is pretty rare in kids, they may have had bleeding post-operatively. But really, once we get into that, those early teen years at the time of menarche is when we really see these different symptoms that occur in patients that, have the potential to menstruate in the form of heavy menstrual bleeding. Next slide. So we know that heavy menstrual bleeding is actually a pretty common complaint in the population as a whole. So we know that some studies have shown that up to 40% of menstruating people have what is classified as heavy menstrual bleeding. But a lot of these patients may also have an underlying bleeding disorder. Depending on the study you look at, between 5 and 20% of adult women with heavy menstrual bleeding are eventually diagnosed with von Willebrand's disease. And this percentage is actually even higher in adolescents, although studies are a little bit different. And so it depends on the population you're looking at, whether you're looking at, patients that end up in hematology, patients that, are admitted to the hospital. But we do know that in menstruating people with bleeding disorders, that heavy menstrual bleeding is the most common symptom that is reported. And I think that's remarkable, especially given the fact that we know from other studies that many women don't even necessarily report, or many menstruating people don't even necessarily report that they're having heavy menstrual bleeding. Additionally, in some adolescents, it may be the first symptom of their underlying bleeding disorder. Next slide. So thinking about how we handle heavy menstrual bleeding, as a member along with Dr. Cannell of the management panel for von Willebrand's disease that was published in 2021, I think it was really important to a lot of members of the panel that we address some of these issues around heavy menstrual bleeding, as well as around management around pregnancy bleeding. And so what we ultimately came to recommend, although again, this is a conditional recommendation because really, sadly, as we were reviewing all of the literature on von Willebrand's disease, there's not really fantastic studies comparing treatment options or that are adequately powered to kind of detect these sorts of things. But we did suggest using either hormonal therapy, which can be anything from a combined oral contraceptive pill to a IUD, or tranexamic acid over the use of desmopressin to treat women with von Willebrand's disease and heavy menstrual bleeding. And that is in people who are not looking to conceive. So it's really important when we talk about heavy menstrual bleeding that the treatment options are going to be quite different based on whether someone's actively trying to conceive. So the second recommendation was actually to use tranexamic acid over desmopressin in patients who wish to conceive, as obviously in these patients, something like an IUD or an oral contraceptive pill is not going to allow them to meet their reproductive goals. Next slide. So thinking about the management of heavy menstrual bleeding, I tend to think about it and talk about with my patients in terms of hormonal options as well as non-hormonal options, especially in adolescents where oftentimes, not typically the patient as much, but oftentimes the parents are a little bit shy to talk about hormonal options. And I think it's also important with this to mention it as hormonal therapy rather than birth control, as that can really be off-putting for many parents of adolescents. But there are progesterone-only options such as the pill, Depo-Provera, the IUD, as well as a subcutaneous implant. And then there's also combined estrogen progesterone options such as the pill, the patch, and the vaginal ring. Next slide. And then non-hormonal options, and I kind of break these down into disease specific. So this would be things like factor concentrates, either plasma derived or recombinant, or desmopressin, although this has been an ongoing issue for our patients, with stimate no longer being available, but this can be used, and people are able to obtain some now, I think, intranasal desmopressin, although it's more difficult than it previously was. And then more non-specific agents such as antifibrinolytics, tranexamic acid, or aminocaproic acid, which actually have been shown to be very effective, not only for people with bleeding disorders and heavy menstrual bleeding, but also even patients without a diagnosed bleeding disorder that have heavy menstrual bleeding, presumably due to other causes. Next slide. So I think it's really important also with the guidelines that we had, we did address specifically the issue of heavy menstrual bleeding and looking at these different options. And we didn't really talk about, factor prophylaxis within that, but factor prophylaxis was addressed separately. That was actually the first recommendation in the guidelines. And it was recommended that in patients with severe and frequent bleeds, that long-term prophylaxis is recommended. And I tend to think about, I think it's really important for us to remember this part of the guidelines, because there are things like, desmopressin and tranexamic acid and hormones that we can use for heavy periods. But factor is also definitely an option. And for patients who may have, a reason not to be on one of those other methods, or, are having severe, monthly bleeding, factor prophylaxis is another option that we should be considering. Next slide. And just in terms of, as we are prescribing these things for our patients, I find the pictorial blood loss assessment chart to be helpful. I think it can be really challenging. I, sympathize with our patients where I know when I go to the doctor and I say, I've been having headaches, and they say, how frequently? And I'm like, it feels like it's every day. I don't know. I think having an actual objective measurement where they can keep track of this, and really us be able to tally that and see, if their score is going down with treatment can be incredibly helpful. Obviously, getting the subjective opinion of the patient is important as well, but this can really show, and oftentimes even show, I've had this, be helpful in demonstrating to the patient the progress that they're making. Next slide. So thinking as these patients are getting older and progressing through their lifespan, the next kind of time where there is different bleeding than we would see in patients that are not menstruating, or are not able to menstruate, is peri and postpartum bleeding. Next slide. So the data on peri and postpartum bleeding with von Willebrand's disease, there is some thought, and there have been some studies that have showed an increased risk of spontaneous abortion in these patients. Other studies have not shown the same, so it's a little bit unclear. But I think that looking at all of the data about the types of bleeding that can occur in patients who are pregnant, who have von Willebrand's disease, it's incredibly important that these patients are tied into hematology prior to getting pregnant, and so that hematology can really be involved throughout the pregnancy, because there is a possible increased risk of antepartum bleeding that has been reported in studies. And then there's obviously the big concern about bleeding at childbirth or following childbirth. And depending on what the study you look at, that risk can be anywhere between 16 and 60%. And it's really, variable and likely dependent not only on the type of von Willebrand's disease that a patient has, but also their overall bleeding phenotype. Next slide. So general treatment recommendations for these patients, invasive management of delivery should be avoided. So things like forceps especially should be avoided. And that's also taking into consideration the fact that with autosomal dominant inheritance, a lot of their babies may also be affected, and we all want to do everything we can to avoid intracranial hemorrhage. VWF and factor VIII levels should be measured at least once in the third trimester, and probably, it would be better to do more than that, but at bare minimum, that should be done at least once during that last trimester. There is probably thought that with minimal levels of like 50%, that the increased risk between someone with von Willebrand's disease and someone who doesn't is likely minimal. Although, everyone has stories of those times where the levels were definitely above that, and there were not the outcome that was desired. And then desmopressin or factor concentrates can be used depending on the subtype of the patient, as well as, you know, what their historical response has been to desmopressin. Next slide. So this is just kind of illustrating what happens with von Willebrand's factor during pregnancy. And as you can see, if you don't have von Willebrand's disease, your VWF levels go up very nicely. They get quite high throughout, you know, pregnancy, but that doesn't necessarily happen with all patients with von Willebrand's disease, and it can be quite variable, as you can see, based on the subtype of von Willebrand's disease that the patient has. It's also incredibly important to remember that the levels drop pretty precipitously after the baby is actually born. And so things like both primary and secondary postpartum hemorrhage, you know, occur during that time when those levels have dropped. And so despite measuring in the third trimester, your patient may have, you know, a nice high level in that third trimester, but acknowledging the fact that that's likely to drop quite precipitously after the infant is born. Next slide. So we did look at a number of issues in the management guidelines around pregnancy, the first of which was looking at neuroaxial anesthesia. And this is I think was a little bit of a loaded topic when we were discussing the guidelines, in that I think there are hematologists that really feel that patients with von Willebrand's disease should not undergo neuroaxial anesthesia. I personally feel very strongly about all of our bleeding disorder patients that we have the tools and we should be able to provide treatment to allow our patients to have, you know, a similar experience to patients without bleeding disorders. And so I don't think it's fair to say, well, you have von Willebrand's disease, so you just need to suffer through it and not, you know, necessarily get an epidural or something that you would otherwise have. But the question here was looking at what VWF activity level to target, and basically, again, very low certainty in the evidence, but the panel ended up suggesting normal levels, so anywhere from 50 to 150 over targeting a higher level. They didn't feel that there was evidence to suggest that that higher level was necessarily needed in terms of preventing bleeding around neuroaxial anesthesia. It was not looking at this in terms of the postpartum hemorrhage risk, so it's important to realize the difference there. Next slide. And then another one that we did tackle regarding pregnant patients was using tranexamic acid in patients with type 1 von Willebrand's disease or low VWF levels. And this, I think, out of all of the management recommendations, had the most support throughout the entire family, throughout the entire panel. It did feel like a family by the end. We had just spent so much time together. But I think, you know, we actually even had considered, like, could we make this not necessarily be a conditional recommendation, because everyone thought there's really very little downside to providing tranexamic acid for these patients. And this also may apply to patients with type 2 and type 3 von Willebrand's disease, because again, there's very little, I think, risk in providing that. And if we can prevent some postpartum hemorrhage, that's fantastic. Next slide. And then lastly, as we kind of progress along the lifespan of these patients, we get to the time where patients are, you know, coming up into menopause and may have issues with perimenopausal bleeding. Next slide. I was really incredibly disappointed when I was preparing for this talk. So I'm a pediatric hematologist, and so don't think a lot about perimenopause, although I will say that when I talk to parents of my patients or you know, people I know that have von Willebrand's disease that are in this age range, I do hear a lot of questions about this and, you know, what should they expect, or, you know, they've had a lot of issues and no one seems to know what's going on. But when I, you know, kind of tried to look in the literature for this, unfortunately, you know, we know this entire population of women, girls, and people who menstruate has been neglected, but I think that even more so, people in this perimenopausal time period are neglected even further. We do know that in all people, whether they have von Willebrand's disease or not, anovulatory bleeding is common, similar to when you're first starting your periods. As your periods are stopping, that anovulatory bleeding can be common and can cause heavy bleeding. There may be excessive bleeding in those with von Willebrand's disease, but this is incredibly understudied. There really is not literature out there you know, significantly to tell us what to expect in this time, or really what to do with this time. I think, you know, in general, there's similar treatment options to what we have for heavy menstrual bleeding, but I think it's also really important to acknowledge the fact that this is a different patient population with different risk factors. And so, my patients that are just starting menarche have very low thrombosis risk. That's different once, you're 50. And so all of these are things that need to be considered. But with that, I would like to hand it over to my colleague, Dr. Cannell, who's going to talk about a few other issues affecting these patients. Thank you.
Thank you, Dr. Wyand. And we'll move on to my slides, where I'm going to talk a little bit first about perioperative management in aging patients, and then follow this up with some issues specifically in transgender care. Next slide. So it's really important to recognize that we don't have a lot of data on what to do with aging patients with bleeding disorders, but it's actually a good problem to have that we now have patients with bleeding disorders who are aging. Life expectancy is increasing as we have better treatments in childhood, adolescence, and young adulthood. And so we have this growing population of older adults who are going to need elective and urgent and emergency age-related procedures. There are a lot of orthopedic procedures in bleeding disorder populations. Von Willebrand disease, while it's thought to be partially protective against cardiovascular disease, does not mean that patients are going to have no evidence of CVD, and that patients are going to need things like catheterization and CABG. And of course, with age and gender appropriate cancer screening, we often come across malignancy that needs to be treated. Next slide. Additionally, in this population, as people get older, we know that there's an age-related increase in the risk of thrombosis just in general, completely separate. And so we do see this in patients with bleeding disorders who have traditionally thought that they really bleed, but they don't have a risk of clotting. And really what's also important to recognize is that comorbidities contribute to this thrombosis risk and to bleeding risk in the setting of surgeries. Hypertension and diabetes and hypercholesterolemia, while we talk about that all being risk factors for cardiovascular disease, they're also risk factors for thrombosis itself. And the comorbidity of cardiovascular disease, concomitant need for antiplatelet agents, anticoagulant therapy, can really make it challenging to manage someone in the perioperative setting who you're trying to prevent bleeding and thrombosis simultaneously. Next slide. This is a slide that comes from an education article that one of my colleagues, Dr. Yazin Abu Ismail from the University of Utah, and I posted, published in late 2021, that really kind of gets at the fact that thrombosis, our traditional areas of venous stasis, endothelial dysfunction, and hypercoagulability do apply in patients with VWD. There are all these various factors that contribute in each of these categories. But what we also know is that with physiologic aging, von Willebrand factor levels go up, platelet activation increases, there's increases in factor 7 and factor 8, fibrinogen, but also increases in Pi1. And so the balance of hemostasis that exists in an older patient is actually quite different than the balance of hemostasis that existed in that individual during childhood and adolescence. Next slide. So in aging patients with bleeding disorders, unfortunately, evidence-based guidelines are lacking. And this is because there really was an underrepresentation of older adults in clinical trials that looked at what to do. There's also the rarity of many bleeding disorders. So we have very little data in VWD, and we have even less in patients with other factor deficiencies. And it's really important to have a multidisciplinary approach to a patient requiring surgery, including hematologists, the surgeons, anesthesia, and other specialists who might be involved, whether it's physical therapy in the postoperative setting for orthopedic procedures, discussions with nursing about why we're giving both factor and anticoagulation in a patient after a cardiac valve replacement. And so understanding this and making sure that the plan is in place at the beginning and that this plan is shared with patients and that they understand what the plan is very important. So what do we have from the guidelines? Well, the data that we do have suggests that for patients needing major surgery, the von Willebrand factor activity, measured by whichever assay is available at your institution, most commonly ristocetin cofactor, and the fact, so VWF activity and factor VIII activity should be maintained at least 50% for at least 3 days using VWF concentrate. Now, you may opt to extend durations of this depending on the type of surgery that's being done. You know, I think of an orthopedic procedure as being very different than an invasive neurosurgical procedure. Many patients with orthopedic procedures without bleeding disorders can go home the same day. And so we probably, with the newer techniques, don't need to extend factor as long as we have traditionally in some surgeries. We also know that prolonged supraphysiologic doses of VWF concentrates may predispose to thrombosis. And I think this is becoming more and more discussed in the bleeding disorders community. In VWD specifically, what are the benefits of plasma-derived versus recombinant therapies? We had, since when the guidelines were published in 2021, there were no data about this, but there have been studies published since showing that recombinant VWF is very efficacious and safe. And so think about a patient who has, you know, a type 2 von Willebrand disease in which their defect is actually in their platelet binding activity. They may not need extra factor VIII that would then predispose them to thrombosis. Minor surgery, we often talk about using desmopressin, also known as DDAVP, a synthetic analog of arginine vasopressin. I think that we need to consider concurrent cardiovascular disease in those patients, especially because desmopressin causes fluid retention and fluid shifts. We all think about hyponatremia with repeated doses, but there are risks associated with desmopressin, particularly in older patients, and many centers have started saying that they will not administer desmopressin over specific age cutoffs, whether it be 60, 65, or 70, or in any patient who has clinically significant cardiovascular disease. The other piece I think that we underutilize is antifibrinolytic therapy. This can be combined safely with VWF concentrates, especially for mucocutaneous surgeries to reduce the risk of bleeding. One of the interesting pieces that hematologists are being asked to comment on, somebody could have VWD and actually have a worsening of their VWD through cardiac valve shearing, or we get asked about acquired von Willebrand syndrome, cardiac valves, and ECMO. And so a lot of these principles apply. Next slide. So these guidelines are available online, open access, free of charge, anywhere in the world that you have an internet connection at bloodadvances.com, both on the diagnosis and the management of von Willebrand disease. And if you want to know more about a specific recommendation, how the guideline panel came to the recommendation, or what studies were used to make the recommendation, and this can be helpful as you're trying to counsel a patient or work with colleagues in surgery about looking at what are the specific risks in patient populations. You can click into that data in detail. Next slide. So cardiovascular interventions, percutaneous interventions are common in older adults. So think of caths with stenting. There's intraprocedural and intraoperative heparinization. And so what I tell patients frequently is we're going to give you factor to basically give you as much of a normal clotting system so that when all these interventions are applied, we can be pretty sure that we're doing it in a balanced way and trying to get the effect that we need. Post-procedurally, antiplatelet use is common. And think about this population that has been told their entire lives, avoid antiplatelet agents, avoid aspirin, avoid ibuprofen, avoid all the NSAIDs. And so there are thresholds that are available, but they are derived from hemophilia data really as to what levels should be there. This is a little bit of controversy: bare metal stents versus drug-eluting stents, and the need for dual antiplatelet therapy. Some centers, my own included here at Brigham and Women's, do not place bare metal stents anymore, and they have data showing similar outcomes if patients can get away with 1 month of dual antiplatelet therapy or 3 months of dual antiplatelet therapy, if they have a high bleeding risk, you can then stop it. So providing prophylaxis during this time period, which is critical for endothelialization of the stent to ensure the best cardiovascular outcomes, and then you can start to back off prophylaxis and the antiplatelet therapy. So as I mentioned, the Prophy guidelines, I refer to the WFH guidelines. These are hemophilia-based guidelines because we really don't have specific numbers for antiplatelet and anticoagulant therapy in VWD. For dual antiplatelet therapy, factor VIII levels should be maintained at least 15 to 30%, and therefore it's reasonable to probably maintain the VWF activity at least this high. For single antiplatelet therapy, levels probably above 1 to 5%. Again, this requires a little bit of discussion with the patients through shared decision-making about what you're going to do and understanding what you may need to adjust on an individual patient basis based on their symptoms. Next slide. Also with cardiovascular interventions, cardiac surgery data are limited in patients with bleeding disorders. We have successfully managed patients through coronary artery bypass grafting, valve replacement, both through open procedures and through peripherally done procedures like TAVR. Patients can need pacemaker placement. And so these are time periods in which having higher factor levels so that the interventionalist, the surgeon, or the cardiologist can actually achieve what they need to for the cardiac outcomes. And I tell patients and the surgeons, don't assume that their hemophilia or their VWD is going to be a contraindication. Let me worry about managing their bleeding disorder. You do what's best for their heart in this situation. Frequently, patients require post-operative antithrombotic therapy. Think about cardiopulmonary bypass and DIC. All of these are in the realm of possibility for older patients, and they may have more extreme presentations of bleeding in the post-operative setting. So when in doubt, have the patients admitted, have them monitored for bleeding, expect to stay at least 1 to 2 days longer than a patient without a bleeding disorder might stay, and make sure that there is a clear plan for how you're going to manage bleeding once they transition to a nursing home, rehab facility, or to back home, so that everybody is in agreement on how to address bleeding. One of the also interesting things, CABG, again, as an open procedure with a lot of risks associated with it. In some cases, it may be better to do multi-vessel cath in patients with bleeding disorders because you can do it all in one procedure through a small incision, a small puncture site in the radial artery or the femoral artery in the groin, as opposed to an open sternotomy. And so this is considered, again, on a case-by-case basis for patients who are really adverse to surgery and maybe at even high bleeding risk. Again, minimizing duration of dual antiplatelet therapy is important so that you can then back off of prophylaxis if needed. Bioprosthetic valves will allow you to be able to forego anticoagulation or minimize length of anticoagulation afterwards, but recognize that it's at the risk of needing reoperation at some point in the future as the bioprosthetic tissue starts to degrade. So a very young patient may require surgery in another 10, 15 years, depending on the status of their valve. I'm going to pivot a little bit here and move into gender affirming care and the intersection with von Willebrand disease. Next slide. I put up this slide. This comes from an online resource that you can see here, referenced below, that there's a lot of terminology, and some of this gets used interchangeably, and some of it is in evolution. We used to talk about LGBT or LGB, and now we're starting to add additional letters and the plus symbol at the end, recognizing that sexuality has many different dimensions. One of the things that I do want to point out here, there are two different T's, and one is to show that the term transsexual is an outdated term that was used in the medical and particularly psychology communities. And the terminology that is being used more commonly today and accepted by the community is transgender. Next slide. Intersectionality is not a new concept. It has been recognized for a while, and there's a couple of different definitions. So the Oxford English Dictionary, of course, talks about overlapping and independent systems of discrimination, whereas the next definition from Merriam-Webster is combining or intersecting, especially in experiences of marginalized individuals or groups. And so if you think of gender and you think of transgender patients, and then you think about individuals who menstruate and already hearing about the lack of data and the focus in research, you can understand that there are very little data in this area to guide how we as hematologists care for this community. Next slide. Some data from the Trevor Project in this 35,000 person survey showed that across the United States, nearly 4 out of 10 LGBT youth had considered attempting suicide in the past year. And that actually was more than half of all the transgender and non-binary youth. Additionally, nearly half of LGBT youth have reported that they wanted counseling from mental health professionals, but were unable to receive it in the past year. And finally, these populations noted that access to spaces that affirmed their orientation and identity reported lower rates of attempting suicide. So I think this is important as a context for understanding how we provide hemophilia care. Next slide. So thinking of mental health and bleeding disorders, just about bleeding disorders, this is across all bleeding disorders that 40% of young adults say they felt less attractive because of their bleeding disorder, and a number reported stress, anxiety, depression, or insomnia. And in a subset analysis, 26% related this directly to their hemophilia. And then in our own population, in the center I work in at the Boston Hemophilia Center, a study done by my colleagues here, Amanda Stahl and Eric Parnas and others, showed that 60% of our patients with severe hemophilia could identify a traumatic incident leading to PTSS or PTSD. Just from experience, this also, I think, applies in the VWD population, although we don't have as much data outlining specific numbers. Next slide. So what do we do for patients who have a bleeding disorder and identify in this population? Well, we have anecdotes, but we need data. We really need studies done in this area, but we do have some guidance of how to move forward. Next slide. These are the areas that patients report fears and anxiety in disclosing their HIV status if they are HIV positive, different identities and having connections with different communities, but not having somebody who has both a bleeding disorder and identifies as transgender, for instance. There are high rates of homelessness, and there are issues, obviously, about perceptions of abuse. And so a lot of these areas intersect and can be challenging for those focusing on mental health. Next slide. So what do we do in transgender health? Well, hormonal therapy may or may not be concordant with the treatment for gender-affirming care. Gender-affirming surgery is a high-risk time period for both bleeding and thrombosis. So you need to not only just manage the bleeding disorder, but their thrombotic risk, similar to what we discussed previously. And as patients go through transitions of what their presenting gender is within their clinic and their staff, there's often this perception of needing to come out repeatedly, especially to staff that may have known them for many years. Hemophilia clinics are often seen as very male-focused clinics, and so patients who are assigned male at birth but undergo transition and identify as female may not feel as connected to the clinic. And the same for patients treated in female traditional clinics such as obstetrics and gynecology and have VWD that are then transitioning to male. Next. So in the intersection of VWD and transgender care, the National Hemophilia Foundation sponsored a State of the Science Summit. And you can read a lot about this. There was a whole compendium released that focused on DEI and understanding how the lived experiences of these populations reflect inequities and how to mitigate provider behaviors. Next slide. So at this point, I think we're going to go into our breakout rooms. I'll turn it back over to Nicole.
You can definitely pass it back to me. Thank you so much, Dr. Cannell. That was fantastic. And thank you so much, Dr. Wyan. I'll just go ahead and pass it over to Dr. Cannell. If you wouldn't mind just sharing top line, couple main key learnings that took place in your room.
Yeah, so our discussion was around surgical management and a lot around really using VWF concentrates in the setting of major surgery to avoid the use of desmopressin so that you're not worried about fluid shifts. You can get your levels where you want. There's a little bit of discussion around continuous infusion versus bolus infusion strategies, as well as the use of antifibrinolytics. There was one follow-up question about use of subcutaneous desmopressin, which is more often used, I think, in pediatrics than in adults. But there are some places that have a little more use of it. And some of the questions about how to actually dose it, similar dose, 0.3 micrograms per kilogram injected subcutaneously. I generally, when I've done it, has been at least an hour prior to the procedure to make sure that there's enough time for absorption.
Thank you so much, Dr. Cannell. And Dr. Wyan, same for you. Top line, what were some of your key takeaways that took place in your breakout?
Yeah, so we talked about a patient of mine that has von Willebrand's disease and really heavy periods, but also really painful periods, who ended up, in addition to having von Willebrand's disease, also having hemochromatosis. So we kind of talked about how to handle that situation because we initially, started her on cyclical hormones and her periods got better, but still during kind of that week or so a month, she was miserable and missing school and very uncomfortable. And really wanted to just get rid of her periods entirely. But the concern with that is, iron overload. And we know with men with hemochromatosis, they require treatment earlier. Her ferritin was already kind of elevated. So we just kind of talked about, approaching those patients, importance of shared decision-making. It can be really tough in pediatrics, especially when, parents and the patient don't necessarily always have the same values or thoughts. But kind of talked about, other ways that you could maybe manage the pain and ways you could maybe try out, maybe suppressing for 3 months and then taking a break or different things. And I always think it's important in those situations to realize you're not choosing a path that you have to continue on, right? You can always suppress and then stop or, not suppress and then start later. That's the nice thing. You're not completely committed.
Well, thank you so much, Dr. Wyan, and thank you so much, Dr. Cannell, as well. It sounds like you had some really great, fruitful discussions. And also feel free to reach out should you have any follow-up questions. We could pass those along to our presenters. We are running short on time here. But in conclusion, make sure that you watch your email for an evaluation from UNMC, and this is how you will access your CME units. And then following this, you will be sent a resource document as well. And in the future, this recording will be available online with resources aside from the breakout. So I apologize, I did not disclose that we were re-recording again, but I hope you heard the little Zoom shout out. And last couple more things. Please come back and join us for event number 4 that is focusing on managing challenges during pregnancy and delivery on May 11th. And I just want to thank everyone who has been here and is attending today. Thank you for your time. Thank you to our speakers for being here today. We appreciate both of you. Thank you to the NHF staff who've helped plan this event out today. And of course, again, I just want to thank all the participants. And again, if you are curious and you are hungry to learn more about VWD, we hope to see you back here on May 11th. Thank you again, everyone, and I hope that you have a great rest of your day.